Was it the internet?
The internet.
The internets.
The interwebs, if you will.
Now
First
back.
up, we have Michael.
Dyson. I'd like to first thank the organizers, and especially our sponsor, Dr. Sharat Raju. So I'd like to talk a little bit about the etiology of melanoma, and especially a few key points about the molecular biology of melanoma. Many of you are aware that melanoma is now the 5th leading cause of cancer in men and the 7th leading cause of cancer in women, affecting about 20 individuals per 100,000 in the US is the most recent statistic. Many people think that melanoma is due to all types of sun exposure. However, it's known that intense exposure in childhood, even 5 or 6 severe sunburns when you're quite young, is highly correlated to an increased risk of melanoma, about 2 to 3 times. Interestingly, differently than keratinocytes, which typically undergo apoptosis after sun exposure, melanocytes do not. And this is actually thought to be an evolutionary advantage in that the melanocytes actually help to protect the keratinocytes until you're of reproductive age. So there's some discussion that potentially the reason that melanocytes don't undergo apoptosis as readily as keratinocytes under UV A and B is due to this potential evolutionary mechanism. So I'm curious, how many of you have been to a tanning parlor in the past year? Have any of you?
Oh, Sharat looks like she's
Sharat?
been there the most.
Okay.
It's real tan.
Yeah.
So it turns out that about a third of the females between ages 18 and 25 have been to a tanning parlor in the past year.
25. Yeah, that's so nice.
And I actually asked Grace this question. She said she had just once. So it was interesting. So certainly tanning booths, any kind of UV exposure increases your risk. There's also a risk in terms of your complexion, genetic background, red hair, freckles, blue eyes. If you have high nevi counts, that's also a risk factor. And there's thought to be 2 ways of really the mutagenesis, how it occurs. There's the UVB pathway, so UVB, and there's the UVA pathway. The UVB pathway, there's direct mutation, C to T transitions which occur. So the nucleotides, cytosine to thymidine. And then there's UVA, which actually uses melanin. There's a complex pathway. So both types of UV are implicated as a risk factor for melanoma. Another risk factor is your genetics. So about 10% of melanomas are actually familial. And clinically, if 2 or more of your immediate relatives have a melanoma, there's likely a mutation in a gene called CDKN2A. And so it's recommended that you take a family history and that if there are more than 2 blood relatives with melanoma or pancreatic cancer, that they get screened for this particular gene. So that's something to keep in mind. There's a wide heterogeneity in terms of genetics for melanoma. So the background, your genetic background likely determines your clinical outcome as well. Another risk factor for certainly your patients, which is important to keep in mind, is immunosuppression. There's a 3.6-fold increase in melanoma in immunosuppressed patients. People don't know exactly why that's the case, but there have been several papers on this topic. And then another risk factor is actually endometriosis. There's about a 1.6-fold increase. And again, the history is not known for that. So talking about the molecular biology, most melanomas are cutaneous, but when they metastasize and become systemic, we're quite interested in molecular biology because we can use targeted treatments for melanoma. In particular, the MAPK pathway, the MAP kinase pathway, is the most important pathway. It stands for the mitogen activated protein kinase pathway. You might have heard of it or remember it from molecular biology. And one of the key members or players in the MAPK pathway is RAS. It's called RAS. And then there are 2 particular molecules downstream, NRAS and BRAF. I won't go into details of how these work, but if you remember NRAS and BRAF, those are two important genes and proteins which tend to have mutations in melanomas. In fact, BRAF is found to be mutated in about 40 to 50% of melanomas, and NRAS is found to be mutated in 15 to 20% of melanomas. So whenever you stage a melanoma, especially if it's systemic, it's important to know if the melanoma is BRAF positive or negative, or NRAS positive or negative. And since all of these, or most of these, are tyrosine kinases, there are drugs, tyrosine kinase inhibitors, which have been developed against BRAF, as well as against NRAS, and a variety of other members of the pathway. Okay, so a little bit about the staging and what to do with it. So this is relevant for you. Most of melanomas are cutaneous, or at least they're found when they're still cutaneous. There's a couple different types, which I'll go over quickly. There's superficial spreading melanoma, which is about 70% of melanomas. And I wish I had pictures to show you. There's nodular, 15 to 30%, lentigo, which is 10 to 15%, and then acral, which is less than 5%. And as I mentioned before, about 15 to 30% of melanomas are found on the head and neck. So it's quite relevant, even though the head and neck only compose about 9% of the total surface area of the body. The general treatment for melanoma is surgical excision if it has not spread. Whether you do a lymph node biopsy depends on how aggressive the tumor is based on its staging. Typically, you'll find for a stage T1 that there's a 92% chance of recovery over 10 years, or survival, I should say. T2, 80%, T3, 63%, and T4, 50%. And the T's are determined by really the thickness of the tumor. And the thickness is what is most important in determining the clinical outcome. Typically, the surgical technique that's used is a wide local excision after biopsy. So whenever you do a biopsy, whenever you suspect a melanoma, you should always do a biopsy with about 1 to 3 millimeter margins, with the idea that you'll likely do a wide local excision in the future. Yeah, you should tend to take a subdermal cuff as well. All right, and then when you do the wide local excision, you'll typically take 1 centimeter margin for T1 and a 2 centimeter margin for T2. And finally, what you should always make sure your patients do who are potentially at risk for melanoma based on these factors that I discussed before is to have them do what's called the ABCDE checklist, where if they notice a nevus somewhere on their body, to look for asymmetry, border irregularities, color variegation, a diameter greater than 6 millimeters, and if the lesion is evolving in any way or changing in any way. And that's really important to do, especially in lighter skinned people, people with a lot of nevi, and people who have spent a lot of time in the sun. So with that's my very brief presentation on melanoma. I would like to answer any questions or go into more details if you are interested.